That's a perfect setup. For those of you who don't know about reference-based pricing or weren't here last year, it essentially is foregoing the PPO and, like Tom said, moving everyone to an out-of-network basis. So I'm going to, I was going to set my timer. I've got 15 minutes to go here, and it's kind of, I said, I can't do it in 15 minutes. Marcia said, it's kind of like a speed date, and she said, you're probably better at speed dating than a full date, so thanks, Marcia. First thing we're going to talk about is, hey, this weekend I learned that someone here was awarded a very prestigious honor, but a CEO of the Year by the Crescent Media / Gannett consortium of newspapers. And does anyone know who that is? That's right. So congratulations.
Yeah, thanks.
And I'm going to give some of my 15 minutes up to just talk about Tom for a second because I think it's important. And I've been friends with Tom a lot longer than we've been working together. And I think that's when I called the organization that gave this award out and said, how can we pick this guy? And they said, of the panelists, it was evident that he loves what he does. And being a TPA, how can you love that? Because when you think about it, when you guys call Tom or Marcia, it's not to say, hey, great job. It's kind of like, you know, they say 99% of all computer error is user error. 99% of all benefit error is user error from the member saying, hey, you didn't pay my claim right. Well, because they don't know. And it's tough to navigate. So for a guy to love his job in the TPA space, I think is extraordinary. It reminds me of something that Tom said a couple years ago. He told me that when Steve Jobs was recruiting John Sculley to come work at Apple, he said, do you want to sell sugar water the rest of your life, or do you want to come with me and change the world? And if you look at Cypress and you look at those trends, that's a pretty big statement, changing the world. But last year, I was out in Colorado talking to one of their customers. It was a new customer that had worked with Cypress about a year. And the guy, I said, how's it going with Cypress? He said, well, let me tell you, John, this is the first year in 3 years that we've been able to give our employees raises. And it's because of the trend reversal that Cypress brought to the table. So most of their employees are low-wage employers. So that is changing the world, Tom, when you can give people a raise that haven't had a raise in 3 years. So it's pretty noble stuff.
Thank you.
And I just, not just talking about it, because I'm proud to call Tom a friend. I had a bottle of Dom sent up to your room. So Wednesday, I want you to celebrate with your staff on that very prestigious award.
That's great. Thank you.
So now getting back to the reference-based pricing, in the speed date theme of things, we're going to talk about the FAQs. The FAQs that the Department of Treasury, Health and Human Services, and the Department of Revenue have issued twice in the past 12 months that gave employers guidance. They're not law, but they're just guidance. And we get a lot of calls from brokers to say, how do those FAQs impact AMPS? And the short answer is they don't. If I had an hour, I could tell you why. But really, the FAQs deal with programs that are true reference-based pricing. And you think about those programs like when we were growing up as kids, and my mom would give me $25 and say, you can go out and get new tennis shoes for school. Converse were 20, Nike were 40. If I wanted the Nikes, I had to come up with some money. So those are the types of programs that the government's concerned about. And really what they're concerned about is how to ensure that the member has reasonable access to quality care. And if a member does buy the $40 Nikes, does that additional spend contribute to his maximum out of pocket? That doesn't apply to our programs, and at a later time I can share with you how. But just so you know, our legal department has you covered there. How have things changed or evolved? 3 years ago when we started really marketing this across the country, we've been doing it for about 5 years, but 3 years ago, I'd meet with a broker and a CFO or a CEO, and 10 out of 10, they'd say, we want to do this, because they heard what the broker would tell them. Here's a way that you can cut 25% off your total medical spend. And the C-level employer, I love it, I'm going to do this. And then by the time we got ready to launch, 1 out of 10 still did it. The next year, it was about 15% of the people we talked to that got excited. Now it's about 25%. And I got a broker that does a lot of it down in Oklahoma, and I said, how do you do it? And he said, if I talk to an employer group and they're this fed up with their employee benefits, I don't bring it up to them. But if they're this fed up, I bring it up to them. So it's not for everybody. It is evolving and changing fast. And from a broker perspective or a planned fiduciary, I think you owe it to your client to bring it up as an option. You could say, hey, got two options here. You got your PPO program or your non-PPO program. There's options. Here's the pros and cons of both. That way you're covered, because what a lot of the brokers that we're doing, they're using it as a door opener. They'll call into your accounts and say, hey, I bet your broker's not talking to you about a way you can save 25% off your total medical spend. We can get a meeting 10 times out of 10 with that door opener. So the number one thing to use our program for is a good defense to say, oh yeah, we have that too. But I say be first about it. And why? Because it's not new. The SHRM, Society of Human Resource Managers magazine, had a study 3 months ago, and 67% of all employers said, not that we're going to look at it, but they're going to implement some type of reference-based reimbursement within the next 2 years. So your employer clients are talking about it. It's time that you bring that solution to them, whether they do it or not. And my promise to brokers and folks like Tom is that when we go out to meetings together, I don't know if we're going to do business with the group, but when we leave, they'll say, thanks. That was interesting. Now we know we have options. What do we like? Options more than anything. What type of employers have moved to a no PPO type solution? It's all over the board. It's tough to say exactly who, but I have a story of a client that of ours that's in central Wisconsin. I met with him at 4:30 on a Friday, gave him the five-minute, 30,000-foot view. And he said, you know what, they're not a Cypress customer, but they're going to be. He said, you know what, in the last 8 years, I've done everything my brokers told me to do. I've done everything my TPAs told me to do, and my costs keep going up every year. Everything. I'm fed up. He said, you look like you're a hardworking guy. I said, yeah. He said, let's shake on it. Let's do this. 6-minute sales cycle. And now they've been a customer for about 5 months now, and the program's working. So it's when you hit that critical point where you're like, I'm done. I have to do this. We've got a client in Arizona. It's 4,000 employee lives. They're a grocery store chain. I didn't know this till 2 years ago, but grocery stores' profit margin's 1%. And when we went and met with them and they saw that the hospital's profit margin was 300%, they said, yeah, we're doing this. Actual results, I'm going to show you some actual results and what's the future look like. So how do we get here? Not to beat up the PPOs, but they're the problem here because of a lack of transparency and prohibition to audit many claims. The bottom is the key here. When I'm talking to an employer group, I say, look, if you don't remember anything else about me, go back to your Blue, United, your Cigna, your Aetna, and ask them, as a percentage of Medicare, post PPO discount, post my wonderful Blue Cross 20 or 50% discount, how much am I paying? Don't tell me about a discount. Tell me about what am I really paying as a percentage of Medicare or some number that's real. And I say, look, even if you don't like me, ask them that. And you think about it, you drive down the road and you see a store that has 50% off, you know it's not real. So why do we take it real from Blue Cross? It's 50% off is real. Our studies show that across the country it's anywhere from $250 to $450 post PPO discount. We recommend payment at 150% of Medicare, so you can see quickly how you can cut your hospital and facility claims in half and get that 25% savings. You guys know this, the cost shifting to the employees that's happened over the past 8 years. And what this really means is these are commingled funds. And a word that we use all the time is your fiduciary responsibility to make sure that you're doing the best thing you can. 10 years ago in the retirement and 401k world, there was massive lawsuits on a lack of fiduciary responsibility. And if you ask Cigna, are they a fiduciary? They say, no, we're not a fiduciary. But you think about it, you're giving your credit card to an ASO Cigna, and they're charging benefits for you. So I say they absolutely are a fiduciary, and Anheuser-Busch does too, as evidenced by their $24 million lawsuit against Cigna, saying you're paying claims twice as often as the TPA. These are how PPO contracts can be harmful. You need to take a look at your PPO contracts. If they prohibit you to have the ability to audit a claim, that's the number one red flag. So what they'll say is, yeah, you can't audit the claim or you can't ensure its accuracy But you don't need to, because we get a 50% discount. So yeah, we're going to make some mistakes here, but don't worry about it, because you're getting a 50% discount. But really, what we counter with is the federal government audits Medicare claims. If you're familiar with that, that's called the Recovery Audit Contractor Program, or the RAC audit program. They find errors on 9 out of 10 hospital claims. So if Cigna, and I'm picking on Cigna a little bit because they have the harshest no audit clause of any of the BUCAs, if they're saying you can't, you're paying for errors. And you have to determine, is it worth the value? And I could show you that it's not, but more so, you got your employee making $14 an hour or whatever, feeding a family of 3. He finds out that you paid a $5,000 error because you couldn't audit the claim. That's where you're going to have a problem down the road. This here is new. We all remember, a couple years ago, we had the $1 million lifetime max, then it was $2 million. Now it's unlimited. About 6 weeks ago, United Healthcare paid a $25 million PPO claim, a $25 million claim. But not to worry, they got a discount, which took it down to $18 million. Now, why didn't we see that 5 years ago? But now we're seeing these claims that can go on forever because there's no lifetime max. And think about what an $18 million claim is going to do to a self-funded employer. I can't think about it. I don't know, what do? Punt and go to the exchange? So here's some real examples that some of the things we talked about last year. Just a couple quick examples. 2013 went under the PPO structure, 717 employee lives. They grew to 747 in 2014. They had a little over $5 million both years. If you see the average discount through their PPO, this is in the Pacific Northwest, so a little lower than your 31.5% average discount. They had a 26% discount, which equated to about 312% of Medicare. With the reference-based reimbursement program, it was a 65% average discount. Now, we don't use the word discount, but we have to say, hey, what is 150 or 155% of Medicare in this rate? What does it equate to off of the billed charges? It was about a 65% discount. So this 750 employer life group was able to save $1.8 million by getting rid of the PPO. Now, every change, there's pros and cons, right? The members could get balanced billed. We proactively work with the members before they get balanced billed. We had 2,630 calls with their employees saying, hey, we audited your claim. Remember, this is only hospital and facility claims. We hope you're doing okay. You had your knee surgery. We took a look at your claim, and we noticed that there were some things on there that your company doesn't pay for. So we adjusted the charges, and just so you know, you might get balanced billed. If you do, don't worry, give us a call. So we had over 2,600 interactions with members where they called up to say, hey, I don't understand my EOB. What's this mean? They never had a member successfully balanced billed. They tried a couple times, but in the Pacific Northwest, they had very little disruption here. Next quick case study is in the neighborhood of 600 employee lives, 2013 versus 2014. They saved over $2 million, and it was 46% average discount. This is in Ohio. The PPO replacement has been going a lot longer in Ohio. It's a lot more proof of concept, and so the PPO discounts have gotten better. So it's 46% in Ohio. We took it up to a 70%, and this employer saved a little over $2 million, or about $3,000 per employee on the plan. Where's it going from here? Give you an example. I mentioned the employer in Arizona, 4,000 lives on the plan. We worked with them for a couple years. In the third year, they rallied together other CEOs, and they put together about 14,000 employee lives, and they did a RFP to the 6 major hospital systems in Arizona, and they said, give us your best and final. And what happened was we helped those employers do a direct contract, cut out the middleman, cut out the PPO at 130% of Medicare, which sounds good, but the better number is guaranteed favored nation pricing, 10% better than any BUCA discount ever. So if United Healthcare gets a discount in Arizona, we get it. So it's better, always better than 10%. And so what the employee does now, they've got John C. Lincoln and Scottsdale Medical Center. If they have a surgery and if they go to one of those two, there's no copay, no member responsibility. If they want to go to Mayo, it's $7,500. So now there's some consumerism where the employee finally has some skin in the game and has to make a choice. That's the future. Direct contracts between the employer and the facility, cutting out the PPO. My contact information is right there, but on the back of your card is the Cypress contacts, and we work in contact or in tandem. So if you can't get a hold of me, call your Cypress rep, and we'll come out and see you together, and we'll give you a projection, what you could save using reference-based reimbursement versus a PPO solution, so your group has an option.
Thanks, John.
All right, well, good afternoon. It's a pleasure to be back here again. The 4th annual conference, that's pretty cool, of Cypress U. I have to tell you, I work with a lot of TPAs all across the country, and this really is a unique event. I don't have another TPA partner that has this type of conference. It's a lot of fun, but it's also really educational. I also have to say I'm really disappointed no one mentioned my favorite band, U2. No U2 fans out there? It's a shock. All right, a couple, all right. All right, well, like Tom said, a few years ago, actually I remember Holly and I kind of standing in the back of the room after that first conference and talking about putting together more of an integrated product where really Cypress and American Health can kind of be like the quarterback, you know. We're the kind of the gateway to, you know, to healthcare as we get the first alert through the pre-certification process, and how we could integrate with some of the other great partners that are here today. And really coordinate with those partners to really maximize the results. And so that was really the beginning of this really neat product that we put together called the Cypress Best Practice Bundle. So I'm going to talk about it today. The results, I'll say, are still quite preliminary. We've got some really good, solid results. I've compared results for some groups that were with us before they added the bundle, and then since. And then some other groups that have had the product for about a year. A lot of our other groups are just jumping on board, but I'll be excited to hopefully get invited back again next year and have even a larger book to be able to talk about. Just really quickly here, just for anyone who hasn't heard of us, you know, we're a national medical management, wellness, and cost containment company. Like I said, we work with a lot of TPAs across the country, none as good as Cypress, of course, but many others. And I have about 2.5 million lives total in our book of business. And again, probably one of the most important things is that we are Cypress's partner for the bundle. So what is this bundle that I've probably said the word 3-4 times already? But it's really an integrated set of services and partnerships, again, to really maximize the coordination and overall reduce claim costs. And so how do we do that? And if you look at the little circle that we put together, again, Cypress and American Health are in the middle as really sort of the quarterback for the program. And using some programs like utilization management, case management, some other programs that I'll touch on today, as well as negotiations, either in-house or through some of the partnerships that Cypress has, we're really trying to address the main areas of claim costs that customers are really concerned about. So transplant, mental health, oncology, dialysis, maternity, and radiology. So we're able to touch on those areas and make sure that we're really keeping our eye on the ball and managing those cases and finding those cases just as early as possible through this product. So first of all, through pre-certification for all inpatient admissions, but I have to tell you, I still work with a lot of customers who are kind of missing the mark because they're only focused on inpatient admissions and not the outpatient. And as you know, more and more surgeries are done outpatient. I swear in a couple years, heart transplants will be an outpatient surgery. You know, it's just really changed over the years. It's also the earliest way to find out about oncology cases. If you wait till they go inpatient, that could be a year down the road, and you've really, again, missed the mark to manage that case. So pre-certification of all inpatient and a robust list of outpatient services as well. Also pre-admission and post-discharge counseling, and again, I'll touch on these as we go. Specialty case management services, including our own in-house specialty oncology, transplant, dialysis, maternity, and mental health substance abuse nurses. Also a review of outpatient diagnostics in coordination with Jim and his team at One Call Medical, and Jim will touch, of course, on those results today. Also reviewing outpatient surgeries and making referrals to Bridge Health, their surgery network partner. Also on the transplant side, managing those transplant cases and referring them to the most appropriate centers of excellence. I didn't mention dialysis, but of course, DCC I know is going to be presenting, I believe, tomorrow, and we're pre-certifying those dialysis cases, and then we'll do a referral over to DCC as appropriate, as well as managing those cases in-house. And then lastly, managing those those mental health substance abuse cases, which seems like every meeting I'm going to lately, I'm just hearing of, that's really on the rise, where some of the highest dollar cases that a group is seeing are those inpatient mental health substance abuse cases. So how can we address those early, get members the care that they need earlier on, and hopefully avoid some of those inpatient admissions? And so we're doing that through our integrated behavioral health product that we built with our partner CurLink. So in terms of that Cypress medical management bundle, again, we started talking about it at the very first annual Cypress University a few years ago. So we launched this product initially in 2012. We were a little bit late, quite honestly, for that January renewal cycle. Then between 2012 and 2014, we were able to add 24 groups. And now, as of March 1st anyway, we have 39 groups totaling 7,000 E's with the product. So just started touching on some of those different components. I mentioned for utilization management, we have a really comprehensive list. So in addition to all inpatient admissions, acute, surgical, rehab, skilled nursing, and mental health substance abuse, as you can see, we have a pretty detailed list of certain outpatient surgeries, outpatient diagnostic services, again, making sure, is this really medically necessary for that member to have the MRI or the CAT scan, and then coordinating closely with the folks at One Call Medical. In regards to continuing care services, that's any sort of ongoing therapies. It's chemo, radiation, dialysis, physical therapy, injectables, all those sort of ongoing therapies that a member might need. And then lastly, outpatient psychiatric and substance abuse. Pre-admission and post-discharge counseling is really a program that we put together to help get members ready for that inpatient surgical stay, but also, more importantly, really try to avoid members being readmitted back into the hospital. And so we can do that by working closely with the member ahead of time, making sure that they understand the surgery that they're going to have, or maybe some alternative options that might be available to them as well, and helping them plan for what their needs are going to be when they get back home. If a member really is not preparing for that discharge back home, they could end up staying in the hospital a little bit longer because they don't have someone at home ready to take care of them. Or they could end up, getting back into their home, not realizing that for the first 3 weeks, maybe they can't lift more than 10 pounds, and therefore they're not prepared and they injure themselves and end up back in the hospital. And then with post-discharge, we're following up with every single member after they're discharged from the hospital, if they don't already trigger for case management, and following up with them to make sure that they understand the discharge plans. They know the signs and symptoms of an infection. They know how to take their pain meds. They've made their follow-up appointments. All those little things that may seem pretty basic, we actually run into a lot of issues in talking to members, and as a result of the conversations, the training, the education that the nurses give them, they're able to avoid them ending up back in the hospital again, which is obviously really expensive. An example of that is, in this case, a 65-year-old male who went in the hospital for knee replacement surgery. Our nurse reached out to the gentleman before he went in the hospital and talked to him about what his needs are going to be and what that aftercare looks like. And then when the gentleman got back home, that same nurse, which is a case manager, reached out to the member, and through that conversation found out that he was having a lot of pain and he was showing symptoms of an infection. So our case manager actually reached out to that member's physician, got him an appointment for that same day, and the doctor prescribed some additional antibiotics to get that infection under control, thereby keeping him from ending up most likely back into the hospital again. And then in terms of case management, I mentioned earlier that we do have specialty units at American Health. So we have specialty oncology nurses that handle anything related to an oncology case. All the pre-certs, all the case management are handled by that specialty nurse. And then we have several levels of review to make sure that that chemotherapy regimen that's been prescribed by the member's physician is the most appropriate and the latest and greatest. And we have many oncologists on our panel as well. We also have specialty units for transplant, making sure it's medically necessary, it's covered under the plan, and then helping to find the best facility to have that transplant done at the lowest cost. We also have special OB/GYN nurses handling those neonate cases, those high-risk pregnancies. With dialysis, we have the specialty dialysis nurses, and again, coordinating with companies like DCC or doing negotiations. And then lastly, under mental health and substance abuse, and doing a close coordination with CurLink. In terms of maternity management, it's really a prenatal education program where the expectant moms really need to go ahead and self-enroll. There's just no other good way to find those cases without having the moms self-enroll. And so they would call us. We have an OBGYN nurse who does an assessment determining their level of risk, educational needs, and then from there making outbound calls every 3 to 6 weeks depending on their level of risk, as well as sending out educational information to that mom and following them all the way through a postpartum depression call about 6 weeks afterwards. High value in that program as well. And then the Integrated Behavioral Health Program is in partnership, like I mentioned earlier, with CuraLink, which is an EAP out of Chicago. And the way we set it up is right on the ID card, members are told to contact CuraLink for any type of mental health substance abuse treatment. CuraLink resolves the cases that they can resolve through the EAP. Those that are more complex are referred over to us, and we assign a mental health case manager to manage that case. So sort of that entry point then into the program, of course, is the all-critical member ID card. And so right on the ID card, it will list that if the member is seeking any type of medical treatment, inpatient or certain outpatient services, to call American Health Holding. If there's any type of behavioral health treatment, to go ahead and contact CuraLink. So on the medical side, of course, that comes in, goes through the pre-certification process. If it's deemed medically necessary, American Health will handle that. We'll also do that pre-admission call for any of those scheduled inpatient surgeries. AHH will then coordinate with other partners, again, One Call, Bridge Health, Transplant, Centers of Excellence, et cetera, and as well as with Cypress to do any negotiations possible. And then lastly, doing that post-discharge call. On the behavioral health side, again, it goes to CuraLink. They conduct an assessment as to the severity of that case. If it's something that is low or moderate acuity, they'll go ahead and handle through the EAP visits. If it is something more complex, they immediately get that over to a case manager to help that member find what the right level of care is and the best place to provide that treatment for them. So I gave you kind of a good entryway into or foundation for the product itself. In terms of results, again, it's a fairly new product. We just really have been getting momentum now, getting groups on, and now we're just starting to be able to kind of talk about results. So we have 3 groups that were with us in our medical management program prior to adding the bundle, and then have the bundle now and have had it for more than a year. So it's fairly small numbers, but I think the results are really good. In terms of inpatient savings, you can see for 2013, we were at about 27,000. For 2014, we went up to 37,000, and that population was the same during those 2 years. Outpatient savings, you can see we went from 2,400 up to 8,000. Some of those groups had a little bit of outpatient, but you can see the benefit and the value of having outpatient pre-cert. There's real savings, as well as it's an early indicator for case management. And then you can see the case management savings really took off. We went from 181,000 to 351,000. I think the main reason being, again, is we've got the outpatient pre-certs, early identifier, as well as some of the other programs. And so that really increased the savings. So we went from 211,000 in savings for that population up to almost 400,000 in the year that they had the bundle. So in terms of total number of employee lives, I told you that it's really just been taking off over 2014 and into 2015. But we have 12 groups, totaling about 1,600 E's that have had the bundle for 12 months or longer. And so I thought that would be the most fair population to be able to look at and again, measure impact of the program. So starting out with utilization management, I'm showing here kind of a breakdown of the different types of inpatient stays, medical, mental health, substance abuse, surgical, non-acute, et cetera, for that population. In 2014, we had about 60,000 in savings, with outpatient another 44,000, totaling 104,000 in inpatient savings. For case management, you can see that we managed about 52 cases during that 2014 time period. What's sort of interesting and surprised me a little bit was psych and substance abuse is the largest area. Again, that's just an area that continues to be on the increase with overuse of pain medications and a whole plethora of other types of issues, unfortunately. And so I think through that CuraLink program, we're finding those cases and getting those members into a case manager to help them and help figure out, do they need to be inpatient or maybe some type of intensive outpatient treatment, which is obviously less expensive. And so in terms of total savings, again, $672,000 in savings for just those 1,600 employee lives. Pre-admission and post-discharge, again, this is a newer program for the population. You know, they were pretty used to having pre-cert and case management. Some of these other programs are newer, but I think the results are encouraging. For pre-admission and post-discharge, you know, it's, again, members aren't necessarily expecting to get a follow-up phone call after they've pre-certified. So I think we can do some education on this program and definitely on the maternity management, and we'll see the savings definitely increase. But just some basic numbers here. For pre-admissions, we identified 11 members for that were going to have a scheduled inpatient surgery. So keep in mind, it's not outpatient surgeries, just scheduled inpatient. And 9 of those members, or 82%, actually participated. Post-discharge, a little bit higher numbers here. We had 45 members identified, and we were able to actually reach 21 of those members. So again, almost half of the members that we reached participated in the program. But again, I think we can do some education there. Also, maternity management. And keep in mind with maternity management, it is a case rate, so it's not as if you know, these customers are paying for the program and not having results. But I really want to reach out to you all over the next couple of weeks and see what we can do to remind members about this program and the benefits of it. Because once they know about it, they tend to love the program. And there's real advantages. We did a study at American Health in terms of the percentage of preterm babies that are in a maternity management program as compared to members that are not in the program. And so for preterm, it's 6% as compared to 11.6% as a national average of moms not in the program. Same thing with low birth weights. We have 6.1% low birth weights for members in the program as compared to a national average of 8. So real value if you can get them in the program. Unfortunately, it's just we don't have a large enough population yet to talk about, but again, I'm going to be reaching out to all the groups with the bundle in tandem with their Cypress account manager and really see if we can work on promoting that program. And then lastly, on the integrated behavioral health program, we received 107 calls through the CurLink program, which is called Support Link. And the breakdown of what happened to those cases is as follows. So 25 cases, which is about 23%, of those cases were actually resolved through those EAP visits of up to 5 phone calls. 5 of the cases were addressed in the EAP, meaning they got some initial assistance through those EAP face-to-face visits, but from there still needed some additional assistance. And so those cases are then referred over to a case manager to help find what the right level of care is for that member. And then 77 of the cases, which is about 72%, were more complex and needed assistance through an American Health case manager. But still, the savings for that program being about $55,000. So total savings then for those 12 groups with the Cypress Best Practice Bundle in 2014 was $842,000. So pretty good number, and I'll be really excited to see what the results are next year. All right, thank you so much.
I'm just going to do a brief overview of our program, what we offer, some features and benefits of this program, how we've worked with Cypress Benefits since 2006, and how this program works, what we do offer. We have 100% of coverage for all major transplants types. First dollar benefit, we offer $1 million, $2 million, or an unlimited lifetime max. We also we cover all the National Cancer Institute phase trials. Absolutely no out-of-pocket expenses for deductibles for the patients when they're in our network. We do offer a travel allowance. It's a great benefit for the patients if they need to travel to one of our centers to have the transplant done. Our benefit periods covers our first dollar. You're going to start at evaluation through 365 days post-transplant. We're covering the hospital, the physician, the pharmacy expenses on that. You have direct payment from AIG, so all providers are paid through us, so it eases the cash flow for the employer. You have complete medical management on this program. Our case managers are involved with these patients from beginning to end. They have a personal relationship. Our case managers are in our house. They are not outsourced, and that's all they do is manage transplants. You also have access to our major facilities with this case management. This program is a standalone, fully insured first dollar benefit. It is essentially designed for self-funded groups. We are actually carving it out of their plan document and insuring it separately through our plan. You are buying a policy, not a network. Keep that in mind. It does protect the employer, and insuring it separately, we can use it against any plan document. The catastrophic expense of this transplant is unbelievable to some people when they have it, when these patients get it, because it's a life-changing event. It's a high dollar cost. This program does contribute budget predictability and stability on their stop-loss rates. We do offer a 10% commission that's built into our rates. Generally, your stop-loss carrier should also offer you anywhere from 2 to 10% for having this program in place. 2 reasons why your carrier should do this. 1, because they don't want to have to pay an excess loss claims if they don't have to. And 2, they certainly don't want to have to do a laser on you, because that would cause you to shop them, and they don't like it when you do that. We do have a high renewal persistency on this program, because once these individual groups get it, they want to keep it. Again, with the example that Tom explained, once they leave, the transplant hits. We offer you extensive marketing assistance, which is why I'm here today to do this presentation for you. And with this program, you can market it to groups of 50 employees and above, regardless of who the stop-loss carrier is, for a pooled TPA program. We came up with this concept to do a pooling partner with TPAs, which is how we partner with Cypress Benefits, and they help market the program for us. We have about 54 pooled TPAs throughout the U.S. We asked them to bring 3,000 employee lives to us so that we can help market this program, which Tom has been very successful at doing that. We do have a high degree of patient satisfaction for this program. It can improve your loss ratio too across your block of business. Anytime you are doing a transfer of risk, it is going to help do that, the loss ratio for your book of business. Our rate increases on this program has only been due to medical trend. We have never raised our rates due to a group's experience. Actually, this year our rates have been stabilized and we didn't have to do rate increases on certain states. There's no underwriting or rating up on the transplant exposure at renewal for our pooled producers. You do have access through our state pooled rates. Our rates are done, we look at it, we stratify it per state, coupled with the population, frequency of transplants that we do for our rating on this program. And again, it does attach to any plan document. The average cost of this program is about $13 PEPM, which is a far less cost than what it would be if it was a laser. But as I go through this too, I'm going to show you a value proposition which will show you that it may not cost as much as that $13. The important part of this program too is working with our TPAs. The most important part about the medical part of this is we ask that the TPA identify the patient and refer them into our program. The TPA are our eyes and ears. They're in the front line. They understand what's going on with these claims, so they're going to refer this patient to us. And as soon as they do that, we're going to take over the medical review, the care and coordination. We'll get them into our transplant network, and we're going to pay the claims. So it takes us all that responsibility off of the TPA. On this chart, you're going to see the average billed charge per transplant type. We like to show you this because this is what minimum is showing us, is those average charges. Here you're going to see it from the year 2000 to 2014. Look how those costs have went up over time. Far too often, transplants are thought of as a case rate. That is just not true. You must remember to include organ procurement, donor charges, anti-rejection drugs, and evaluations to those charges with a complete episode of care. You must also think of it as a year or longer. Sometimes it will take 2 to 3 years before a person will go to have a transplant. Now we're going to show you on Cypress block of business the current groups that they have with this program. They have 39 groups currently with us. The total premium on that group is $820,000. Currently for 2015, they brought 4 new groups to us. In 2014, they put 11 new groups, and in 2013, it was 8, and they have been a pulling partner with us since 2006. Here I'm going to show you 3 examples of a transplant that we have with Cypress Benefits. We're showing you average bill charges on this. We're going to show you the total that was paid by AIG. We're showing you the annual premium that was paid on the groups for the entire employee counts, the savings that was the result of this payment, and we're showing you the transplant type. We wanted to do this because we wanted to show you some of the savings and the cost of some of these transplants. The interesting one here is your heart transplant. On the average bill charges, you will notice that it was almost $1 million. This individual had 2 good things going in their life. First of all, they were young, in their early 30s, and was in good physical health, with the exception of the bad heart. They came to us. It was a great success story. We got them in, got their transplant. However, the patient wanted to have their cardiac care rehab done at another hospital that was close to their home. Our nurses got involved, and they were able to go to this hospital, get this patient in for their cardiac rehab. And we did a negotiation with a 20% savings with no balance billing back to the patient. So it was very successful. He was healthy after this. Within 2 months, he was back to work. So the negotiations going out of the network does help. It is important for our nurses. They do that. If it's not always going to be, we do get in front of it and try to do a negotiation if it's out of our network. And this is the important piece that we always enjoy showing, and this is the value of the product. We like to show this because we always like the clients to see, because they think we're adding costs to their stop loss. And for this example, we wanted to show you, we're going to start to the far end where it's showing you the 250 employee lives. We're showing you their spec deductible for this is $60,000. Their estimated stop loss premium is $300,000. And then we're showing you what it would cost for this group to add our transplant premium, which would be $30,000. Usually when we're presenting this, we get 2 pushbacks. One of them is going to be from the producer and from the group. The producer is going to say, well, I have stop loss. Why do I need this extra cost? Well, we're going to show you because usually your stop loss carrier can't protect you because of lasers and rate-ups. The second one is we're a small group. We've never had a transplant. Well, this is a foolproof way to prove our point. When this group has a transplant, they would have to internally fund that through their spec deductible. That's the agreement that they have with their stop loss carrier. We are showing you if this group, when they have that transplant, the cost for them to internally fund that would be $20 PEPM. And the math on that is your 250 employees divided by 60,000 divided by 12 months. And then we're showing you, if you look at our transplant premium, what the PEPM on that would be. The same math shows you it would be $10. So even at this level, it's still a good value. But the reality, again, of the stop loss world is probably not going to cover it due to rate-ups and lasers. So we're showing you what, with the probable laser on this group of $300,000, and what the cost would be then, their PEPM, it's going up to $100. But if they had our program in place, they're no longer looking at a spec deductible of $60,000 because we're a first dollar benefit. That goes away. They're only looking at that $10 PEPM. And if you have this in place, your stop loss carrier should give you some kind of a discount. We are showing you if this was placed with AIG stop loss, we would give you a 4% discount off of your premium or $12,000 savings. So what you should do is take that savings of $12,000, apply it to your transplant premium, so your actual cost for this program is only $18,000, or your PEPM would only be $6. So that answers that first question of about what I have stop loss, why do I need this program? The second question was, we're a small group, we've never had a transplant. Well, we go further to go ahead and explain that at the bottom. If the group would have a transplant in the first year, and yes, we do pay transplants for the first year. If you take that probable laser of $300,000 and subtract the first year premium, your savings would be $282,000. But let's say the group doesn't have that transplant till the second year, and they've paid 2 years of premium. And premium could be just a little bit higher due to medical trend, but also your stop loss will go up too, so it kind of balances out. The savings, if it was with 2 years of premium, would be $264,000. And what we're trying to show you here, if you would continue to do the math until this would be a negative financial value, this group would have to go 16 years without a transplant before they would be upside down on the program. And we know in today's world with medical technology evolving, that is impossible for this group to do. So that employer needs to make a decision. Do I want to fund this internally through a spec deductible with a probable laser at $100 PEPM, or do I want to fund this through the transplant program with a $6 PEPM? We call that a no-brainer. It's an easy answer to that. So now it's a budget predictability because that employer knows now what he's paying, $30,000 for premium to cover that transplant. It allows him to be able to buy new computers or hire a new employee so he could also make his company a success too. And that is the program.
My company works with Cypress. Many of you as Cypress employers and your members to manage radiology benefits and radiology costs. It's a business we've been doing for over 20 years. Last year we scheduled over 1.5 million MRI, CT, PET scans across the country. We're going to do close to 2 million tests this year, not only for Cypress but for payers across the country. Not a lot has changed since I spoke about radiology a couple of years ago. I mean, the technology continues to expand dramatically. Radiology, particularly high-tech scanning, is the first line of investigational medicine for most physicians, and it will continue to be. I truly think, as does my company, that in the years to come, an MRI test or some advanced PET testing might become a standard test of a physical exam for a lot of doctors, and will be covered. Radiology is 10 cents of every claims dollar that goes out the door. You don't know that, but it is. It's 10 cents. MRI, CT, PET scans, high-tech imaging is about 7 of that 10 cents. The other 3 cents is X-ray, flat film, ultrasound, DEXA scan. Not a lot you can do about that. That's the domain of the physician office. But high-tech imaging really is where the money is in imaging. There's a real difference in where the test is performed in terms of cost. And there's 2 things that drives where the test is performed. I bet if everyone in here raised their hand, if they've had a test, an MRI, CT, PET test in the last 3 years, it'd probably be 75% of the room. There you go. I bet out of those that raised their hand, 75% of those tests were scheduled by the physician that ordered that test, their office. Raise your hand if it was. There you go. And the reason is 2 things. One, physician offices or physician groups, 70-75% are aligned with hospital systems. So they're incentivized to keep the business within the system, keep the revenue within the system. The other piece is that patients don't really understand it, and the reason they don't understand it is because they don't treat it like a financial transaction. They treat it like a continuum of care. My doctor wants me to go here, so this must be better, or must be the best place that I can go. My doctor wouldn't send me there. Well, it's really not the best place you could go. It's as good as most, or even many, but it's not the best place you can go. It's an economic, it's a financial transaction that takes place. I kid my mother-in-law because she'll drive 25, 30 miles to save 4 cents on a gallon of gas, but she just had an imaging test done at Vanderbilt. And I go, why? Why did you do that? That's crazy. That's because that's where she was sent. And she lacked the understanding in terms of investigating what other alternatives might be out there. And that's where my company comes into play. It's a great slide right here. If you look at the facilities on the left, they're hospitals. Look at the facilities on the right. These are imaging centers, diagnostic imaging centers. Those imaging centers are about 5-6 miles from these hospitals. They provide the same service that these hospitals provided, but at about 70-80% less of the cost. So there's a real difference between where the test is performed. And we work to really not engage patients, but enlighten patients. Engaging a patient is getting them on the phone. Enlightening them is educating them to become a better consumer, a better steward of medical dollars in terms of how they spend those dollars. So we're on the back of Cypress ID cards for members. When MRI, CT, PET test is ordered, they will, the physician office will contact us, or working through American Health Holding, they will contact us and let us know. We call the physician office and we work with them to get the test scheduled at one of our facilities that we're contracted with directly. Once we are able to get that negotiation worked out, we then contact the patient directly to let them know that we're calling on behalf of ABC Employer and Cypress to schedule your imaging test that Dr. Smith's ordered for you. We got a call from Dr. Smith's office, and we work to get those done. It's a very collegiate, a very patient advocate type of approach, and the difference in cost is substantial. And I want to show you that. This is real life. These are two cases where we got a call, one from St. Nicholas, this is Sheboygan, one from St. Nicholas, and one from Memorial in Sheboygan. And we had an imaging center, Smart Choice Imaging, contracted $500 for an MRI. I think one of the imaging centers for the MRI was $1,800, the other was $2,300. So an incredible difference. And you know, the equipment is the same. The radiology groups that read at both the imaging center and the hospital are the same radiologists in Sheboygan. Oftentimes the equipment in an imaging center has to be better than what's at a hospital because it's not a build it and they will come. They don't have a built-in referral panel coming to them. They have to go out and market to physicians to send tests to them. And they do that in terms of having better equipment, more often the equipment is calibrated, radiologists that read within a certain amount of time, a whole host of different things. But it's a real opportunity. So I pulled the last 240, 250 tests that we've done with many of your groups, but we've done with Cypress, and you can see what the allowed amount, and that's after billed charges. Billed charges and then what the PPO reprices it to, which is about 70% of billed charges, 70% of billed charges. You can see what the PPO allowed is, about a little over $350,000. And then what our rate was after we scheduled it and moved it from the hospital to an imaging center, went down to $161,000. That's real money because that would have happened. That's what's happening. That's real money. And that's a reduction of 56% of savings at $200,000. If you look at it on a single case, it boils down to $1,500 to $600. So I was just penciling something a minute ago. You figure if a member has a 20% coinsurance, then if they'd have stayed with the hospital, that would have been a $305 20% coinsurance. If they'd have gone with our recommendation, it would have dropped down to $135. So that's $170 savings. That's like going out and paying $1 in a slot machine and getting $171 back. I mean, it's a beautiful thing. It's free money, and everybody wins. So in summary, the program gets hard dollar savings impact. It's very transparent. It doesn't interfere with plan design. It doesn't interfere with other network partners. It really sits on top of the network and works. We do all the heavy lifting for the patient. And again, the patient gets the tests they think they need. The doctor gets the information they're looking for. They get it done very quickly, and we get it done in an imaging center that is very cost effective and works very well with our program. And we move the member again from engagement to enlightenment. It's a financial transaction, just like you're chasing that 4 cents on a gallon of gasoline. So thank you very much. If we're working with you, we appreciate your business. And if not, we'd appreciate doing business with you.